AEDs. All right. So anti-seizure medications, we used to call them AEDs for anti-epileptic drugs. So you'll see that a lot. But it was recognized at some point that the medications we use treat seizures. They don't really treat epilepsy in the sense of what's causing the seizures. That would be a goal, is to have medications that are anti-epileptogenic or things that stop the process of producing seizures. Also, the term epileptic has, kind of been wiped out of our lexicon to the extent that we can because of the stigma of saying that. So we call them now ASMs, not AEDs, anti-seizure medications. And we in epilepsy, like all of you, think of these as kind of the traditional or first generation ones versus later generation ones. The traditional ones are really these five. The oldest one in current use is phenobarbital. I mean, the first medication used for epilepsy was actually bromide. This was introduced by a Sir Charles Lockhart, a British neurologist at like the turn of the last century. But and bromides were pretty effective, but they were also very toxic. So since around 1915 or so, phenobarbital has been used. And then phenytoin was discovered in a lab here in Boston, where all of American medicine begins, especially neurology, um, by doctors Merritt and Putnam. Sometimes you'll hear those names, the Merritt-Putnam Symposium at the American Epilepsy Society. They tried different molecules in seizures against cats and found phenytoin worked, which is called Dilantin. And the next one to come out was carbamazepine or Tegretol. Then valproate. That valproate was sensational when it came out, Depakote. Now you hear all these bad things about it, but the truth is that came out in the mid 70s, 1975-ish or so, and it was groundbreaking for all those patients with generalized seizures because it still is very effective for generalized absence or tonic-clonic, so-called grand mal seizures. And the other one to round off the traditional list is ethosuximide or Zerontin, which is specifically and only for absence seizures or petit mal, petit mal, those terms, what we call absence. Now, here are the newer anti-seizure medications, right? So we have second generation throughout the 90s to the early part of 2000s, and then the third generation since around 2010 until now. Dr. Bourgeois was my predecessor here at Boston Children's Hospital, and this was his specialty, was anti-seizure pharmacology. So the second generation one's a big sensation was felbamate. You may know it as Felbitol. When that came out, I was in the early part of my career as a junior faculty, and we were so excited. I never forget going on the television on a news show and talking about the first new seizure drug to come out since Depakote, which again was in the 70s. So it was like 20 years later. This was so effective, it was incredible, and it still is. But about a year after it came out, it was basically almost taken off the market because it had caused so many deaths from liver failure and aplastic anemia or loss of the blood count. And that's when I learned a lesson. I learned a couple lessons early in my career as a physician. One is not to jump on the new kid on the block, the new drug, the new bandwagon, because it takes experience with lots of people over time to know what's going on with these medications. And two, it takes 100,000 exposures. So when a new drug is released and they tried it on 1,000 people or 3,000 people or 5,000 people, that's nothing. It took 100,000 exposures to realize that felbamate, which was thought to be the safest drug ever released when it came out, turned out to be one of the most dangerous. In the meanwhile, the same year, gabapentin came out, which all of you know is Neurontin. That is still very safe and very effective for headaches and pain. Not too good for seizures, but it came out as a seizure med. Then lamotrigine came out. There was a flurry of these meds that came out in what we call the second generation. You might know this one as Lamictal. This is a very good medication for different types of seizures, but it can be associated with a terrible rash that, if it becomes internal, can be life-threatening. So now we have to go very slowly in the way we start that medication in terms of the dosing. Around the same time, topiramate came out. You may know as Topamax. That's the brand name. These are the generic names. And this is a very good medicine if you want to lose weight or to treat migraine headaches. It's not bad for seizures. It has side effects. Then there's some other ones like tiagabine. You probably never even heard of that one because no one uses it. But one that really has been a blockbuster is levetiracetam, which you probably heard of by the brand name Keppra. And why has this been so big on the market? Because even though it can cause irritability, it's very safe. It doesn't affect the blood count, the liver, all the body organs. It doesn't seem to be associated with teratogenicity. In other words, a problem with the fetus after a pregnancy when a woman's taking it. So this has been a very widely used medicine. Then oxcarbazepine came out. You might know it as Trileptal, kind of a new version of Tegretol. I mentioned Tegretol in the earlier generation, the first generation. Trileptal might be safer than Tegretol, although honestly it's not, but that's how it was marketed. And then another one came out, zonisamide, Zonegran, Pregabalin, Lyrica. These are pretty good medicines, but they have their issues, and they're not that effective. And then we have the third generation, okay? So these are the ones I thought we would focus on tonight because that's the newer stuff. Now, when I say 2008 is new, maybe that doesn't sound new to you, but to me it's new because I've been in the field for over 30 years. So to me, it's still new. So rufinamide or Banzel, lacosamide or Vimpat, vigabatrin or Sabril, clobazam or Onfi. Ezogabine is an interesting medicine, but it went off the market after a few years because it was causing blue discoloration of the fingernails, toenails, and the eyes. Perampanel was an interesting drug when it came out. Fycompa, eslicarbazepine or Aptiom, brivaracetam, Briviact is kind of like another Keppra. And then there's some much newer ones. So for example, Stiripentol, which has actually been used in Europe forever, got approved in the US by the Food and Drug Administration in 2018, as did cannabidiol. I would say cannabidiol is the big blockbuster because, it's sold as Epidiolex for epilepsy, but it's CBD. And everybody wants to be on CBD because they think it's natural. The truth is, it's not really natural. It's still a drug. It's not an herb. I mean, it's kind of like saying marijuana is natural. I mean, it does come from a plant, but it's a medication. It has all kinds of side effects. It can even damage your liver. It's not something everybody should be taking just because they think it's cool to take it. But it is used for epilepsy successfully in some of our most severe epilepsies. For example, Dravet syndrome and Lennox-Gastaut syndrome. It's actually indicated for that. Does it work? Yeah, but not really any better than the other drugs. People like it because they think it's alternative. It's actually not. It's just another medication to us. Then there's cenobamate, which looks like it's pretty effective. It's also called Fycompa is the brand name. That's pretty new, but side effects. The latest one sort of to hit the block is fenfluramine or Fintepla. This was Fen-Phen, the old weight loss drug back in the 50s. It was taken off the market because it caused heart disease. But now it's been reintroduced because it seems to help kids with epilepsy and they get their echocardiograms done regularly to make sure their hearts are okay. And so far, there haven't been problems with that. So this is kind of like a list of where we are with the seizure meds. So what's the profile of newer anti-seizure medications? Several are designer in the sense that they were designed to treat seizures, but some were just discovered through massive screening programs where they'll take every compound they can throw at, like throwing the kitchen sink at a problem and see what helps seizures in animal models and then figure out which ones help. But there are some new mechanisms of action that are interesting if you want to get into how they work. They overall have a pretty broad spectrum. It's not like Xarontin that's only for absence seizures. Interestingly, there are more and more medicines coming out now for specific syndromes. Like I said, Epidiolex is specifically indicated for Dravet syndrome and Lennox-Gastaut syndrome, although we use it for all kinds of epilepsies, but that's how it's indicated. That's how it was studied. That's how it was approved by the FDA. Most of them have less central nervous system or cognitive side effects. That's good. And most of them have a better safety profile than the older ones, although that's not true for every one of them. Now, there is less potential for allergic reactions like the Stevens-Johnson syndrome, except for lamictal. That's the second generation. One of the big benefits is some of them really don't interact with other meds like Keppra. That's a big benefit of Keppra as well as gabapentin or Neurontin. We think there are less congenital malformations. In other words, in a baby who was a fetus born to a mother who was taking it for her epilepsy, the rate of congenital malformations in women with epilepsy taking seizure meds decreased from 6% to 4.5%. It's still considerable, but we know that Depakote is the big problem with teratogenesis in the fetus. Of course, some of the new seizure meds aren't really new. They're just kind of lookalikes of the older ones with some improvements. But I have to say, there hasn't been a lot of impact on intractability. What do we mean by intractability? We mean if you have intractable epilepsy, it means medications don't work. The epilepsy is intractable or it's not responding to medication, and we should be looking at other interventions like the diet, the ketogenic diet, or variations of that, or surgery. And epilepsy surgery has exploded in the last 5 years or so with the laser treatments and with the neuromodulatory devices, not just the old vagus nerve stimulator now, but the RNS, the responsive nerve stimulator, the DBS, the deep brain stimulator. So there are all these new surgical options for medically refractory or intractable epilepsy. On the other hand, the surgical options aren't necessarily cures either. So we shouldn't get too excited that just we're going to have surgery, just because we're going to have surgery, we're going to stop the seizures. I wish it was that easy. I think the future is going to be things like focused ultrasound, but we're not there yet. We're working on it. Another thing about the seizure meds is they're still not anti-epileptic. They still don't get at the underlying foundational cause of the problem. They get at the seizures, which is one of the major manifestations of epilepsy, of course, because what is epilepsy? You know, it's a concept. Do you know there's a debate in the field right now that we should be eliminating the term because of so much stigma, and it really doesn't. It's not a disease that you can see under a microscope or do an MRI and see epilepsy. The only real biomarker we have of epilepsy is the EEG, because it is a cerebral dysrhythmia, an abnormal rhythm of the brain. So what is epilepsy? It is a concept that a person with epilepsy has a increased risk or a decreased threshold of having a seizure. That's what it is. Lots of causes, lots of types, lots of co-associated impacts we call comorbidities. The new medicines tend to be more or sometimes much more expensive than the older ones. So those are my general comments, and I could go through some details on the newest ones because I thought that might be useful. But you guys can tell me, you can stop me or ask specific questions if you want. I was going to go through a few little facts on the new ones. So for example, Fenfluramine just came out 2020 as Fintepla, but remember I said it was Fen-Phen. I think the company that makes it is called Zogenix. I can't keep all my companies straight. Maybe they changed the name because sometimes these companies change names, or they sell themselves to other ones. But again, it was an appetite suppressant, really called Fenfluramine. The Food and Drug Administration approved it as an orphan drug for seizures associated with those same two syndromes that the Epidiolex is approved for, Dravet and Lennox-Gastaut. These are pretty severe epilepsies. They studied it in a little over 200 patients. Now, remember I said you need 100,000 to be confident. So I'm personally not confident, but it seems to be going pretty well. About 70% of the patients had a 50% reduction in their seizures in the clinical trials. That's good. That's what they go by, is how many patients had a 50% reduction in seizures, but not 100% reduction. There may be some, but what they mainly use as the primary outcome measure is how many patients in the study had their seizures drop by half or more. And the answer was 70%. However, because of its potential toxicity to the heart, it is only available through a so-called REMS program. That stands for Risk Evaluation and Mitigation Strategy. And so it's a little bit complicated to get through all the paperwork for that. It's not like you can just pick it up at a pharmacy. No way. What are the adverse effects? Sedation, drowsiness, lethargy, that's all kind of the same thing. and ataxia, loss of coordination or balance. Decreased appetite, weight loss. Well, that's how it was used back in the 50s. There are other ones too, like diarrhea or increased salivating called sialorrhea, elevation of blood pressure, abnormalities of the EKG, the heart tracing, or sometimes called ECG, for electrocardiogram, not the EEG, the electroencephalogram. You can get a serotonin syndrome. So we have to be on the lookout because part of the way it works is having a serotonin effect. You might recognize serotonin as an important neurotransmitter. You know, if you take Prozac, say for depression, what is it? It's an SSRI, selective serotonin reuptake inhibitor. It increases your serotonin. But if you have too much serotonin, you can get shaking and diarrhea and rigidity, fever, and even more seizures. So a lot of people with on epilepsy meds describe suicidal thoughts. So it's put in as a side effect. But the truth is, depression is very common in epilepsy, understandably. So it's not unusual to have suicidal thoughts with or without the medication. So it's always hard for us to know, is it the medicine or the underlying epilepsy? Now there's a black box for this medicine. That means the PDR, or the physician's desk reference, has a special warning. Remember I said about heart toxicity? Valvular heart disease, the heart valves can get scarred, and also problems with the lungs, the pressure in the lungs. And that's why we have to get an echocardiogram, like an ultrasound of the heart, before starting and regularly, and even after finishing the medicine. So we start with a certain dose, we go up every week. Now, we have to be careful when we combine our medicines. For example, you'll notice that the target dose of fenfluramine, 0.2 milligram per kilogram twice a day, is lower. It's about half of what it is here, because that's if we give it with the clobazam or stiripentol. This has to do with drug interaction. So it's really important when taking medication that your physician analyzes what other medicines are going in. The pricing, well, it's confusing to be honest with you, but it's pretty pricey. There's a calculation here that if you're 3 years old, which means you're about 15 kilos or say 33 pounds, the dose, if you get up to the standard dose, it ends up becoming over $260 a day or $95,000 a year. What's the bottom line? If the medications work, it makes sense. But if they don't work, we don't want to continue these expensive medications. What's the point of spending all this money if it's not working? Remember, if we go back to the earlier slide, 70% had 50% reduction. That's not bad. The 30% that didn't certainly shouldn't be kept on this medication. Another new one is cenobamate. It's a pretty interesting one called Xcopri because it seems to work in a lot of cases that the other ones don't. It kind of sounds like felbamate, although they are different. So this was approved for adults, but we use it in children as well. And there were about 40% responses over placebo, meaning 40% of the patients in the trials had over 50% decrease in seizures. It's a controlled substance, so it's a little bit more cumbersome for us to prescribe it, but it can be done. It can cause a lot of tiredness, fatigue, double vision, diplopia. It can shorten the QT interval, so we have to check an EKG. It can cause the DRESS syndrome, which is a drug reaction, in other words, a rash. It can cause all kinds of things, but it has been pretty effective. And this is not to look at the numbers, but just to get an idea that we go for the very low dose, 12.5 milligrams a day for 2 weeks, and we build it up every 2 weeks. And an adult will get to a maximum of this dose, or maybe 200. It says maintenance 200. That's as high. It says maximum 400. I've never found anybody could stay awake beyond 200 or even 150. But almost $15,000 a year. So again, something to use if it works. Now, cannabidiol, I mentioned CBD because there's a lot of interest in it. Makes sense. I never forget when when the story of Charlotte's Web came out with the little girl named Charlotte in Colorado with Dravet syndrome, responded to this medicine. I was in DC at that time. There were families from all over the country that literally moved to Colorado so they could get CBD because at that time it was legal in Colorado and nowhere else. Now it's legal in many states. So the FDA ended up approving this in 2018. This is years after the Charlotte's Web story broke, which was like, I don't know what year, but probably like 2010 or something like that. And it's been approved for these syndromes here, which can be very difficult to deal with: Lennox-Gastaut, Dravet, and tuberous sclerosis. They studied over 500 patients, and the interesting thing is, of the patients who had better than 50% response, which was about 40%, in the trials, 20% had that response on placebo. So the difference in the rate between those who took the active medicine versus placebo was only 15, 16%, which is 1 out of 6 responded. And that's what we're interested in clinically: is what's the number needed to treat? How many people do you need to treat with Epidiolex to get the outcome we're looking for? And the answer is about 1 in 6. So 1 in 6 people on it are really going to have what we're looking for, and the other 5 or so will not. So it's worth using in the one, but not the other 5. Now, there are some patients who become seizure-free on this, so it's not impossible. It can really work. All right. Side effects of the CBD or the Epidiolex: tiredness, basically, sometimes diarrhea. That's because it only comes in a liquid that's very oily, and it's not the medicine, it's the oil that it's in. This oily substance can give you loose stools. Sometimes we'll see decreased appetite and weight loss, which people think sounds good, but in a child, it's really not good. We can see a rash. We can have elevated liver functions, especially if given along with valproate or Depakote. And it's a Schedule 5. It's a controlled substance. Actually, I don't really think it is. I think that might be an error because it's easy to prescribe this. You can get it anywhere now without us putting special codes on the prescription. But it's a drug. It's not benign. It's not natural. There's people who take it because they think it's benign and natural. It's not. It does have effects on our liver. This is the cytochrome P system. It can increase the ONFI levels. That's the clobazam. It can increase levels of a lot of our meds like Topamax, Zonegran, rufinamide, Aptiom, Briviact, and other things too. The pricing is interesting. If we have a 20-kilo patient, that's like a 6-year-old, and we give them the full dose, which is 400 milligrams a day, and we give them the liquid, it's about $2,000 a month or $24,000 for a year. It's a lot of money. I realize insurance may cover it, but it's still a lot of money. So again, useful, but not when it's not working, shouldn't be used. One of the newest ones that come out is Stiripentol. They call it Diacomet. I don't like the name, but that's what they call it. I told them it was a bad name. Their marketing people did not do a good job, in my opinion. I already told them that. So this has been approved for Dravet syndrome. If you're on ONFI, which is a little crazy, but that's the way it was approved because that's the way it was studied. And they found that about 70% of people had about a 50% reduction in seizures compared to lower reductions on placebo. And the average decrease in seizures also was about 70%. So that's pretty good, pretty good. There are lots of interactions with other medicines that can cause tiredness, decreased appetite, weight loss, loss of balance, loss of muscle tone, behavioral issues. It can affect the blood cell count, so we have to follow the blood count, or it's a CBC, which stands for complete blood count. But otherwise, it seems pretty safe. It doesn't seem to affect, say, the liver or the kidneys, the pancreas, those things that can be a real problem with some of our medications. Pretty expensive drug if you stay on it, 45,000 a year. So to conclude, because it's been about 30 minutes, so I didn't want to go too long with this because it's hard to pay attention to all this stuff, I know. But what is the place of the newer anti-seizure medicines? Newer ones can be better, but they're not necessarily more effective than the older ones. They're usually not introduced too soon because we don't have as much experience with them. And in general, if you have to give 2 seizure meds, the chance of another one working is less than 50%. So it almost doesn't matter what medicine we use. If the first one doesn't work, it's rough. The second one doesn't work, the chances of meds working completely go down, but it's not impossible. This came from The Economist, and ill for every pill. I don't really know. we have a tendency to look at medicines to fix things, but we have a real problem with the epilepsy and we have to use medication. I thought I would mention seizure rescue because it's always on everyone's mind. What do we mean by seizure rescue? It means instead of taking a medicine every day, or in addition to taking a medicine every day, have something available to stop a seizure, whether it's a cluster or a prolonged seizure. By cluster, we mean acute, repetitive, or repeated seizures. For most people, a cluster means 3 or more in an hour, but that changes based on the person's baseline. Some studies use 2 or more for 24 hours. So the cluster definition is really individualized. Then there's status epilepticus, which means state or prolonged seizure, defined as 30 minutes, but we use an operational definition of 5 minutes because a seizure that actually lasts 5 whole minutes is the one that has a predilection to go 30 minutes. The vast majority of seizures stop well within 5 minutes. Febrile seizures are a little different, but in someone who has febrile seizures or in someone whose seizures get worse with fever, sometimes we'll use a bridge of the rescue medicine for a few days while they're sick. Just like in catamenial epilepsy, in other words, in women who have seizures mainly with their period or worse with their period, we may use rescue with their period. So what are the available seizure rescue meds? The one that's been around forever is Diastat, which is the rectal diazepam or Valium. And it's indicated by the FDA for 2 years and older. Now, Nasalam and Valtoco came out in the last several years. Nasalam is an intranasal or, a nasal spray. Midazolam, its indication is 12 years and up. Valtoco is nasal diazepam, Valium, just like Diastat, same medicine, but given nasally. And they got an indication down to 6 years, which is more convenient for parents, of course. It doesn't mean you can't use midazolam less than age 12, but that's not the way it's FDA approved. It has to do with the way the studies are done. Now, Diastat is this rectal gel, right? It actually came out in 1997, so it's been around now a long time. It can be stored at room temperature. It gets dialed and locked in at the correct dose, and there should be a green band so you can see that means it's dialed in properly. And basically, the dosing works by age. If they're a little child, we give a certain amount, a 0.5 milligram per their weight in kilograms. And as you get older, the dose is a little lower per weight. That's just the way dosing works. As you get older, the dosing is not completely based on weight as much. Where you give, now it comes with instructions how you lie the child down on their side, and you have to use your thumb to remove the cap, and you lubricate the tip, and you bend. They even show you how to give a rectal medication and to put it in, count to 3 slowly, and hold the cheeks together so it stays in. This will come with the prescription, but I just wanted to show it. Whereas the Valium nasal spray is Valtoco. Again, approved 6 and up. It's as safe as the intravenous. It can be given during a seizure, can be given between seizures. It has an alcohol base. So some people will get like a gasping syndrome where they'll have gasping breaths and can get quite sick from it. So that's just one thing to be aware of. Not everybody tolerates it that well. A lot of people will have a little nasal tingling or pain, congestion, epistaxis, which is a nosebleed, dyschezia, which is a bad taste. But that's minor compared to this syndrome here. And the dosing is weight-based, but basically there's a certain dosage range for less than 12 and for 12 and up. So let's just say you're an 8-year-old. That's 30 kilograms. So 0.3 times 30 is about 10. So it'd be 10 milligram. And it'll be 15 milligrams for the older adolescent. It stops there. That's the top dose. The dosing will be between 5 and 15 milligrams, basically. And you can see it comes as 5, 10, 15. It even comes as a 20 for adults. And when it comes as 20, it's not really 20 in one. It's 10 and 10, and you give one on each nostril. The 15 milligram comes as a 7.5 in each nostril, whereas a 10 or a 5 comes as a single puff. So it teaches you how to use the plunger with your thumb and put it in the nose and give a nasal spray. This is remarkable compared to only having rectal medicine for years. So that's the Nasolam. Now, it's not unheard of and very common outside of the United States to give buccal midazolam, which means in the cheek. And you have to draw it up in a syringe. We used to do this all the time before these nasals came out. And you draw it up in the syringe, you have it ready, and then you give it right in the cheek. The problem with that is if someone's having a seizure and their mouth is clenched, you may not be able to open their mouth. And you don't want to stick anything in the mouth. Really, you don't have to, because the person could bite it off and aspirate, or in other words, swallow down the wrong pipe and get really sick. So we're not really into this in the US much. But if you went to Europe, they use it all the time. They don't have these expensive nasal ones, as far as I know. At least they didn't until recently, if they did. Because there's always risks of putting something in the mouth. But still, it's doable. And I want to mention one other medicine before I stop. Clonazepam or Klonopin has the ODT, orally disintegrating tablet. These are very nice tablets because they're like powder. They just fall apart as soon as you put them under the tongue or in the mouth or on the tongue. And that works really well for someone who's having a cluster of seizures, but you don't give it to them during the seizure. You give it to them like afterwards or in between to try to prevent any more. So that's what I mean by the clonazepam orally disintegrating tablet. It's kept a lot of kids out of emergency rooms. So I like them, but not so much to use during the seizure, kind of after it's over and you feel like you want to give some protection. Now, there's some things in the pipeline. There's an inhalational that might be coming out to stop a seizure in 30 seconds. There's an auto-injectable that's supposed to be coming out. Like, you have an EpiPen. If you're allergic to something and you stick it in your thigh, that's supposed to be coming out for seizures. There's supposed to be a buccal soluble film. In other words, it goes in your cheek of Valium. That should be coming out. So there are new things that are going to be coming out. And that is my summary of where we are in 2024 with anti-seizure medicines. I stopped sharing to give you a chance. Oh, hi, Danielle. Good to see you. I just saw you.
Bruce was here to say hello as well during your session, so he listened.
Well,
thank you, Dr. Pearl.
He should have had his comments or his ice skating, but hockey, I should say. But that's kind of a summary of the traditional first generation seizure meds, the second generation, the third generation, where we are now, and the seizure rescue meds. So I'll stop there, and you can bring up any topics you want, and then we can close. I congratulate the Epilepsy Foundation of New England and Christine for organizing these.
Questions can also be done in the chat too. So if you don't feel comfortable speaking the question, you're more than welcome to also put your question in the chat as well.
I have a question, Dr. Pearl. Can you tell us a little bit more about the gasping syndrome that's associated with Valtoco, or could be?
Yeah, you probably hadn't heard of it because I've actually never heard of anyone having it, but it's been reported that probably the benzoyl peroxide that's in the stuff makes some patients just start gasping and unable to breathe and get really sick and basically code and need 911, get acidotic, and then you wouldn't give it again. But I had actually never heard of anyone having it. It's just in the literature. So I think it's got to be incredibly rare.
Got it.
When I came
be like a
across,
deterrent, then you would just,
nah,
yeah, and that'd be a 911 call anyway. So
it would be, and it'd be like I think it'd be the first time ever. And if the person didn't have it after that, they wouldn't have it. I think. I actually came across it when I was preparing this talk for like a conference I was going to in Chile or somewhere like that. And I came across it and I thought, oh, I would have to include it. Now we have a question in the chat. Is there a benefit to using a brand name versus a generic? This has been a question for years and years and years. And this is hard because when when generics became a big deal, when a lot of these drugs went off brand, and we're talking 15 years ago, all the neurologists were saying, oh, you got to go brand name only, brand name only. Why? Because the FDA allows a certain latitude. I was told the generic could be 20% stronger or 20% weaker than the brand name. If it's stronger, you might get side effects. If it's weaker, you might get seizures. And so therefore we said, oh, everyone's got to go brand name. But then the studies came out and it turned out the generics were working just as well for almost everybody. And over time, the cost of healthcare got increasingly out of control. And the insurance companies basically stopped covering brand name, even if we said the patient needs brand name, without real documentation that they really need a brand name. It's actually very difficult to document that someone really needed a brand name unless they went on generic and it failed them. So I would say this, what we say is generic is perfectly fine because it's the same active ingredient. As long as you get the same brand of generic every time. The problem with that is sometimes the generics will change on you and you don't know. You go to CVS and you get your generic for years, and all of a sudden they give you a pill that looks a little different, different color, different size, and they go, well, we changed generics because it was less expensive for them. That is a theoretical risk. So it is a quandary. I don't think there's an easy answer. For one thing, how important is it? If you say you're on a brand name and you're still having seizures, even the brand name's not working. We try to use generics consistently with the same brand. And if a patient goes on a new generic and has a new problem, then we try to check a level and see if it's low, or we just raise the dose, or whatever the situation is. And that's about the best answer I can give you. It can be very difficult to get insurance coverage for brand. The brands are not better. The difference is there is a consistency that you may not always have with a generic. It's not a better quality, it's a consistency issue. It's a great question. And people are still struggling with it. Doctors, patients, insurance companies, everybody. Now, this is a very interesting question that came up by Courtney and Daniel. What is the definition of working for a drug? No seizures, fewer seizures? Well, you know, in a Voltairean best of all possible worlds, it would be no seizures and no side effects. The truth is that is not realistic for everyone. And sometimes if you said no seizures, you'd have to intoxicate a person with so much medicine that their quality of life is not worth it. And some seizures are not that bad, like myoclonic, little muscle jerk, or occasional epileptic spasm or infantile spasm, or an occasional absence. The ones we try to prevent are the grand mal, the generalized tonic-clonic, which means stiffening and twitching, the grand mal. And we try to prevent them because they're dangerous, they're life-threatening. You can have SUDEP, which, as you know, is sudden unexpected death in epilepsy patients. These are associated with grand mal. So we are focused on trying to stop grand mal. But to stop every little seizure, forget it. If it makes you so sick, it's not worth it. So the definition of working, to me, is individualized. There's epilepsy that is so mild. The Chief Justice of the Supreme Court has epilepsy, John Roberts, and he's like the chief legal officer in the country, right? So you obviously can go very far. You know how many medical students and residents I have with epilepsy, and they went into medicine because they have it? I have had patients with epilepsy go into medical school. So you go to medical school, you're a smart kid. I don't care what you all think. The smartest kids go to medical school. That's just the way it works. Of course, I'm biased. And we've got them with epilepsy right here under my training for years. On the other hand, epilepsy can be devastating because it could be associated with an underlying encephalopathy that affects not just seizures, but the entire brain and development. We are not going to push for 100% seizure control in every patient because it's not possible. We even have these fancy surgical devices that I mentioned briefly. Even those are palliative, not curative. So the answer is very individualized. And that's why I say epilepsy is not a single disease. It's kind of like autism. Now we say the autisms because there's so many forms of autism. Now it's called autism spectrum disorder, right? We don't even say Asperger anymore. That's just part of the spectrum. Well, epilepsy is on a spectrum too. And again, it's a concept. It's not even something tangible. But it's a fascinating concept if you're in my position. I spent my whole life studying it. Go.
I'm so sorry, Dr. Pearl, there was another question. It said, with so many options in terms of medication, how do you decide which medication is best to implement first?
Very interesting because the way we select medications are pretty much based on the seizure type and the EEG. Because when you tell me the seizure type, like how it looks, and the EEG, we call that the electroclinical association or correlation, then I know exactly which medicines to use and I know which to avoid based on the way they work, their mechanisms of action. On the other hand, some of the newest drug approvals are not based on the seizure and EEG anymore. They're based on the syndrome. For example, trofinetide, you probably never heard of, but it just came out for Rett syndrome. I mean, who ever heard of having a medication for a syndrome? But that's how it was approved because it seems to get at whatever's associated with the cause of Rett syndrome. It's not, it's one example. We say cannabidiol is for Lennox-Gastaut and Dravet syndrome. Well, Dravet syndrome has both generalized and focal seizures. So what med do we choose? Well, now they're really studying it based on the syndrome. There's a pretty severe form of epilepsy called CDKL5 deficiency disorder, or CDD. And a medication called ganaxolone was just approved specifically for seizures with CDKL5 epilepsy, not based on the EEG so much, not based on the seizure type, but based on the underlying gene that's causing it. Although it doesn't mean we really understand why it works, by the way. But we are changing a little bit our medicine choices to be based on the underlying cause. But still, in general, we pick our seizure medicine based on the type of seizure and the EEG. EEG is the electroencephalogram, the brain waves. And then a question here, is surgery or RNS contraindicated to refractory seizure? No, no, no. If anybody may benefit from epilepsy surgery or an RNS, it would be refractory epilepsy, because refractory means it's refractory or unresponsive to meds, but it might be responsive to surgery. That's the whole point of surgery. And the goal here is, once we decide a child or an adult, anybody, any age, neonate, has medically refractory epilepsy, or intractable epilepsy, that means it's not tractable, not responsive. It means that person should be evaluated for surgery, whether it's curative or palliative surgery. And surgery has all different forms. Another question that comes out of this is, well, what is the definition of medically refractory epilepsy? We used to say you had to try 5 drugs and they failed. That was years ago. The definition has since been changed to 2 meds. The current definition of medically refractory epilepsy is if someone has had good trials of 2 different anti-seizure medicines, whether alone or in combination, and the seizures persist, they meet the criteria for medically refractory epilepsy and should be evaluated for surgery. In just the last year or so, people are even loosening that definition, and people in the field are now arguing and debating very actively right now that even if you've been on one medicine and you have an underlying lesion or cause causing the seizures, like a tumor or something in the brain that we can see, like what we call focal cortical dysplasia, or maybe hippocampal sclerosis, mesiotemporal sclerosis, even one medicine and the lesion is good enough to say surgical candidate. So we are using surgery now way more aggressively than when I started in the field 30 years ago. I have seen many, but I have seen major transformations in my career in epilepsy. What are they? One, there are way more medications available now. 2, the ketogenic diet and its variations have become standard of care. They're no longer fringy or alternative, sort of. 3, the surgical options have exploded. 4, genetics. the transformational effects of the mapping of the human genome. Remember the 90s, I think it was the 90s, was the age of the mapping of the genome or something like that. Now that the human genome has been mapped, we are linking so many epilepsies with genes that we are making diagnoses now every day that we never made before. I mean, we've heard of Dravet syndrome, and I knew Charlotte Dravet because I had a chance to examine patients with her at a big meeting in New York many years ago. But we didn't know Dravet syndrome was caused by the SCN1A mutation, that gene of the sodium channel. So now we do the gene sequencing studies, and we are making diagnoses in patients that we used to say they just had terrible epilepsy or Lennox-Gastaut syndrome or Dravet syndrome or West syndrome, this Oda-Hara syndrome, you name it. I could name 20 syndromes off the bat. Now we have all these genes that are showing us the actual causes of the epilepsy. Absolutely a huge change in my career. And I guess one other change, and this is the one I kind of almost didn't want to talk about, but I already did, is seizures aren't benign. When I was in training, we'd say, oh, you know, it's just a seizure. It's okay. You don't have to take the med. You can't die from a seizure. But that's turned around. We know you can die from a seizure. I mean, why are we kidding ourselves? People with epilepsy have shorter lifespans, and they have SUDEP, sudden death. So we say it now. We just say it now because it's better for us to talk about it than you to learn it from Dr. Google. And it's better for us to have that in our minds when we plan our treatment plan. And it's because it's a serious thing. I'm not joking around. If I were joking around, I wouldn't bring it up. But I'm just bringing it up because it really represents a mood change, a sea change in our perception of the problem compared to when I had finished my training back in 1990 is when I finished my training. You never heard anybody talk about these things back then. Never. I think we're just more open now about stuff too. And I've learned not to hold anything back. I tell it straight because if people need to know. If they don't hear it from us, who knows what they learn from? And all the kids learn stuff from social media, which is a disaster, by the way. Now you're getting my real opinions. I agree with Florida. I think they want to make TikTok illegal for the kids or something like that. I don't know. I mean, if we're up to me, we'd be like Texas and get the cell phones out of the kids' hands. I have 4 children of my own and 5 grandchildren, so I have a personal stake in this. And by the way, anybody who thinks legalization of marijuana is a good idea, come talk to me about it and find out about the kids we have in coma from the overuse of marijuana. And find out about my patients who are so hooked on it that they're having seizures left and right because they can't get off the marijuana. So if anybody thinks it's a good message to legalize marijuana, then you put your head in the sand. Don't you love my editorialization? I do. I think I'm funny, but you go ahead. I'm telling you straight.
Thank you, Dr. Pearl, so much. We do have a couple other just last questions. I know we're coming upon 7:53. One of the questions was on the funding for medications. Is that how funding for meds is following the syndrome? So asking about how the funding for the medication, do they just follow syndromes?
Wait a minute. Are you reading a question or are you saying
I
it?
am reading a question. Yep, by Courtney and
Oh,
Daniel. Yeah.
follow-up question. Is it that funding for meds is following syndromes?
Yeah.
Funding. I'm not sure what you mean, but I don't think so. I mean,
I can clarify if it's helpful.
Yeah.
You said that now medications were coming out that were addressing specific syndromes, and I was wondering if research funding was trying to solve the syndromes as opposed to trying to solve epileptic.
Yeah, I mean, it's not so much funding, but it's a different way of doing the research. So it's a good question because we used to just have seizure clinic, but now we have Dravet clinic, Lennox-Gastaut clinic, CDKL5. And so we're studying these populations that are more homogeneous. If you just study 100 kids with seizures, they're all over the place. One kid has 100 seizures a day, one has one every year. So now we study by the syndrome. It's a more pure sample. And because of that, the drugs are getting approved based on who they're tested in. But I'll be honest, if it's working for a bad syndrome like Epidiolex, we'll use it in other patients too who don't have that, because if it works in that syndrome, I don't know why it couldn't work in somebody else who had a similar seizure type, say a similar EEG. That's a great question. Yeah, thanks. And it says the surgery safer or more successful It is. It is. I could talk about this for an hour, but we only have 5 minutes. Let me just say this. When I was in training, I'm starting to sound like an old guy, I know, but you get the benefit of experience. We used to do these huge craniotomies. We lifted up the whole skull and put a grid on top of the brain under the dura, so a subdural grid, and some depth electrodes in the brain. And it was terrible. The patients would wake up so sick, headaches, vomiting, fever. One eye would be swollen shut within a few days. But that's how we recorded seizures. Now we use this stereo EEG. It's like stereo sound, you know, where you have sound coming from different speakers, different parts of the room. The stereo EEG puts in these tiny little electrodes and teeny little burr holes, and we can get real deep in the brain where we really need to go, not just on the surface. And we can get real specific where we need to go. And it sounds brutal to put it like a spear in the child's brain or an adult. The truth is, they're incredibly well tolerated. We don't really see problems. I'm not going to say 0%, but we hardly ever see problems with it. The patient has it done. They come out of the operating room. They feel fine. They're able to just start eating normally. We record the seizures. We see way more specifically where they're coming from. And then we know exactly where to go. And now we have this laser that in some cases we can just burn it out with a laser. We call it an ablation. It's really a burn. We're burning out the tissue instead of going in there and taking out all this brain. So things are so much more minimally invasive now than they used to be that it's way safer. That doesn't mean it's 100% safe. You still need anesthesia. There's always a risk to going under the gas, but hey, we've all been put to sleep for our wisdom teeth or one thing or another, right? There's still risk of that. There's still surgery. There's always risks of surgery, but it's nothing compared to what it was even 10 years ago.
And thank you so much, Dr. Pearl. If there's no other questions, I don't know if we have any other questions or comments, but if you do have additional questions, I will put my email in the chat and you can actually email me any additional questions that you may have, and we can hopefully get those answered for you at a later time. But Dr. Pearl, thank you so much for joining us today and being with us. I just want to say thank you for sharing your time with us.
Well, I want to say Brooke has her hand up. I don't know if you wanted to say something, Brooke.
Go for it, Brooke.
I just saw that.
I came in late.
Okay.
My son actually, he's on his third febrile seizure. When do you get to a point where you say, okay, we need to see a neurologist for him? How many seizures does one have? Febrile seizure does a child have in order to see a pediatric neurologist?
Yeah, because febrile seizures are really common. We see them in 1 to 2% of all children in the US. And by the way, 5 to 10% of kids in Japan, because they're genetic factors. So when I go to Japan, they all have so much epilepsy, it's unbelievable.
Mm-hmm.
So I'm giving a talk in Taiwan in a few weeks, but thank God I'm doing it by Zoom because I'm giving conferences in California and Taiwan the same weekend. But anyway, if it's a simple febrile seizure, which is 5 minutes or less and generalized, not focal, then there's no real number. They can just see the pediatrician. If it's a complex febrile seizure, meaning longer than 5 minutes, or focal, which means one part of the body way more involved, or repetitive within 24 hours, more than one within 24 hours, then they should see a child neurologist.
Okay.
Or if they start having non-febrile seizures, definitely see a neurologist.
Yeah, because I have epilepsy and we're trying to figure out if it's genetic or not. So,
well, we have a whole epilepsy genetics program that you can just
yeah.
do our epilepsy genetics program. We can figure that out.
Okay. I appreciate it. Thank you.
All right, you guys. Thanks for joining. Good night.
Thank you.